morning everybody. Today we are going to discuss regarding fractures of the hand. So first we are going to discuss regarding Bennett's fracture. So you can see here that the fracture of the base of the first metacarpal is the metacarpal which belongs to the thumb. So fracture of the base of the first metacarpal, okay, intra-articular fracture of the base of the first metacarpal is Bennett's fracture. So Bennett's fracture is first described by Irish surgeon Edward Bennett in 1882. It is the base of first metacarpal intra-articular fracture. So you can see here, this is the thumb, this is the metacarpal, this is the proximal phalanx, these are the carpus, and this is a oblique intra-articular fracture of base of first metacarpal base oblique intra-articular fracture is extending into the joint, so it is an intra-articular fracture. This is called Bennett's fracture. So mechanism of injury is axial blow directed against the partially flexed metacarpal, usually in fist fighters. So whenever there is a fist fight, if there is an axial blow directed against the partially flexed metacarpal, there is a tendency for fracture of base of first metacarpal. So now comes the anatomy. The base of metacarpal is pulled radially and dorsally by abductor pollicis longus, while the distal attachment of adductor, it levers and pulls the base further dorsally, okay, thereby giving an avulsion fracture. Avulsion fracture is, you get a small volar lip fragment which remains attached to anterior oblique ligament. So anterior oblique ligament that anchors the fragment, the volar lip fragment, to the trapezium, tubercle of the trapezium. So the volar lip fragment is attached to the trapezium by means of anterior oblique ligament, so which gets usually avulsed from the base of the first metacarpal. You can see here this one. So this is the base of the first metacarpal. There is a fracture, okay. So this is the trapezium. This fragment is attached to the trapezium by means of AOL, anterior oblique ligament. This is pulled dorsally by means of adductor pollicis, and this is pulled radially by means of abductor pollicis longus, okay. So this is there is another fracture here. So you can see this is a fracture, okay. This is a thumb and this is a fracture here. So two variables are more important in Bennett's fracture. One is size of the volar lip fragment and the amount of displacement of the shaft. Size of the fragment, volar lip fragment, amount of displacement of the shaft of the metacarpal. So clinical features is history of injury or blow, the swelling and pain of the carpometacarpal region, painful restriction of movements of first carpometacarpal joint, pain on gripping, dorsiflexion, and thumb appears shortened. So normal range of motion of first carpometacarpal joint is along the flexion extension arc, it is about 50 degrees, abduction adduction arc is about 40 degrees, pronation supination is around 15 degrees. So diagnosis is by X-ray, and we get AP oblique, we can get AP oblique views of the X-ray, and lateral view is Billing-Jeddas lateral view. So true Billing-Jeddas lateral view is hand pronated to 15-20 degree on a cassette, and tube is directed obliquely 15 degrees distal to proximal, okay, centered over the carpometacarpal joint. This gives a best view for the volar lip fragment, okay. So associated fractures of the trapezium and ulnar collateral ligament injury. So treatment options are: one, closed reduction, next closed reduction and internal fixation, and open reduction, internal fixation. So indications for closed reduction are: one, if it's an undisplaced fracture; next, if it's a minimally displaced fracture and an old age with medical comorbidities, we need to go for closed reduction. So method is by giving a splint or a cast, leaving the IP joint free. You have to leave the IP joint free. IP joint means the metacarpal. You have to leave the joint between the proximal interphalangeal and distal interphalangeal joint. So we have to leave this IP joint free. If we put a thumb spica cast for 6 weeks. In first CMC joint, loss of stability is more important complication than stiffness. Because more chances for instability than stiffness in carpometacarpal joint. So indications for closed reduction internal fixation are: one, in which reduction can be achieved with no dislocation. Pure fractures in which reduction can be achieved with no dislocation of the joint, then we need to go for closed reduction and internal fixation. So method is by we go for traction, counter traction, and K-wires are passed. K-wires are passed from the distal to the proximal fragment, and we transfix the both the fracture fragments to the carpus, a neighboring metacarpals. Indications for open reduction are: one, fracture dislocations, open fractures, failed closed reduction, if there is any tissue interposition, and a late unreduced dislocation. So method of open reduction internal fixation are: without ligament reconstruction, with ligament reconstruction. Without ligament reconstruction, we directly go for only K-wire fixation. With ligament reconstruction, we go for Wegener's techniques. We split the FCR tendon, we drill holes in the fragments and fracture fragments and go for ligament reconstruction. So treatment, then we check the X-ray. If on the X-ray if there is more than 3 mm incongruity in the joint, we go for open reduction internal fixation. Open reduction internal fixation with cortical screws is probably the best. 2.4 mm cortical screws, 2.4 mm, 2.7 mm cortical screws. Technique, it is more demanding, more secure, and active range of motion. You can see here that there is a fracture here, there is a fracture here, there is a fracture here, and this is the base of the first metacarpal fracture, intra-articular, which is fixed with K-wire passing from distal, this is proximal, so distal to proximal fragments, and transfixation to the neighboring metacarpal or carpal bones, so as to secure the position of the fracture fragments. So post-op treatment is thumb spica cast for 4 weeks. 10th day you do suture removal and window for pin tract care. Complications: malunion, persistent subluxation of trapezio-metacarpal joint, for which we need to do a osteotomy. So next comes the Rolando fracture. Rolando fracture is, you can see here that this is an intra-articular fracture of the base of the first metacarpal, like the Bennett's fracture, but the fracture configuration is different. Here it's a T-shaped or a Y-shaped fracture. It's a T-shaped fracture or a Y-shaped fracture. Okay. So in Rolando fracture was first described by Rolando in 1910. It's a type 2 thumb metacarpal fracture. Bennett's fracture with a large dorsal fragment. It's a fracture of the base of the first metacarpal with Y or T-shaped intra-articular fragment. It's probably a comminuted Bennett's fracture. Rolando fracture is a difficult fracture to treat, least common among adult thumb metacarpal fractures. Open reduction internal fixation can be attempted only if there is a single large dorsal and volar fragments. Open reduction internal fixation of comminuted fractures is difficult and can be done only by experienced surgeons by AO techniques. What we do is we do traction, counter traction, and fix it with K wires or screws. We can also put an X-fix, external fixator, can be a reasonable alternative. If the joint surface is incongruous on the check X-ray, we immobilize the thumb for a minimal period. And early active motion to remold the badly distorted articular surface. So next comes the gamekeeper's thumb. What is gamekeeper's thumb? Gamekeeper's thumb is, why did we get this name? Gamekeeper's thumb is because it was seen as a occupational deformity in British gamekeepers. It is a laxity of ulnar collateral ligament without any history of trauma, which was seen as an occupational deformity in British gamekeepers. It is most common among skiers due to fall on the outstretched hand, which give rise to ulnar collateral ligament injury. That's why it is also called skier's thumb or gamekeeper's thumb. So mechanism of injury is valgus or abduction force, probably combined with hyperextension. Hello? बोलिए. देखिए मेरे को एक घंटे के बाद कॉल कीजिए ना. हाँ अभी. जय कृष्णा. Mechanism of injury is valgus or abduction force, probably combined with hyperextension. The ulnar collateral ligament, dorsal capsule, ulnar aspect of the volar plate, and occasional rent in the adductor aponeurosis with avulsion fractures of its insertion on the volar base of the proximal phalanx. So what will happen is, this is gamekeeper's thumb is basically a tear in the ulnar collateral ligament. So you can see here, this is probably the left thumb. So left thumb, this is medial, this is lateral. So this is lateral, this is medial, this is radial, this is ulnar. So there is a collateral ligament. This is a metacarpal, this is the proximal phalanx. So this is a metacarpophalangeal joint. So metacarpophalangeal joint. There is a radial collateral ligament here, there is a ulnar collateral ligament here. So whenever collateral ligament is a ligament which is there on the sides of a joint. So this is a ulnar collateral ligament, this is a radial collateral ligament. So whenever there is a tear in the ulnar collateral ligament, the joint opens up on the medial side, giving rise to this typical instability. Okay, so that's why the attitude of the thumb is like this. Okay, so you can see here that so ulnar collateral ligament injury, gamekeeper's thumb is a ulnar collateral ligament injury. So normally what will happen is, the ulnar collateral ligament is covered by adductor aponeurosis. So whenever there is a valgus and abduction force to the thumb, or if there is a rent in the abductor aponeurosis, there is a tear in the ulnar collateral ligament. So whenever there is a tear in the ulnar collateral ligament, what will happen is, this ulnar collateral ligament, the joint stretches and the ulnar collateral ligament falls out and it is covered by the adductor aponeurosis. Usually the ulnar collateral ligament should be covered by adductor aponeurosis. Okay, so whenever this joint opens and there is a tear in the ulnar collateral ligament, when this thumb tries to relocate, the adductor aponeurosis falls back without the ulnar collateral ligament. So that's why this injury is most unlikely to heal, because the ulnar collateral ligament. The proximal part is here, the distal part is inside the adductor aponeurosis, is covered because of the tissue interposition of the adductor aponeurosis between the fragments of the ulnar collateral ligament. This injury is most unlikely to heal without any operative intervention. Okay. So whenever there is a thumb angulation is sufficient, the ligament can rupture and can displace. If the ligament becomes trapped outside, it is called Steiner's lesion. If the ligament is trapped outside, it is called Steiner lesion. Steiner lesion. Okay. A trapped ligament, you can see here that ligament is trapped here. Ligament is trapped here. A trapped ligament that is not surgically repaired, it will give rise to chronic instability of this metacarpophalangeal joint. Metacarpophalangeal joint, because the ulnar, there is no collateral stability here. The phalanx tends to open on this side, giving rise to chronic instability. So what is Steiner's lesion? Steiner's lesion is a total tear of the ulnar collateral ligament with adductor aponeurosis interposed. It prevents adequate healing. Okay. Clinical features are painful swollen metacarpophalangeal joint and maximum tenderness on the ulnar aspect. Okay. So we have to differentiate if it's a partial tear or a complete tear. So diagnosis is Steiner lesion. Steiner lesion is tender at the ulnar collateral ligament just proximal to metacarpophalangeal joint. So valgus stress at the metacarpophalangeal joint in flexion extension, valgus stress at the metacarpophalangeal joint in flexion and extension, and compare the amount of radial deviation with the opposite side. Okay. So if it is more than 5 to 15 degrees, it is positive. In 30 degrees flexion, if it is more than 5 to 15 degrees more on the affected side compared to the opposite side, it is positive. Difficult to suspect and diagnose when it is associated with proximal phalanx fracture. And routine X-ray before the VST to rule out any shear fracture and radial side of the head of the proximal phalanx. So you can see here, a routine X-ray should be taken before the valgus stress test. So valgus stress test to rule out any shear fracture of the radial side of the head of the metacarpal and the proximal phalanx. Okay. Always a routine X-ray should be taken first, and then a valgus stress test view should be taken. VST is valgus stress test view. Okay. So valgus stress view is taken by, you can see here, we are giving a valgus stress here at the metacarpophalangeal joint and taking an X-ray to see if there is any opening of the metacarpophalangeal joint. So here you can see this is a valgus stress test view. The position of the limb on the X-ray cassette is like this. We are giving a valgus stress test, valgus stress here on the metacarpophalangeal joint, and on the X-ray we are able to see that there is an opening here, opening on the metacarpophalangeal joint on the ulnar aspect, suggesting ulnar collateral ligament injury. So diagnosis, MRI is 100% sensitive to Steiner lesion. Ultrasound can be done if it is done by a skilled person can detect a Steiner lesion. Differential diagnosis is Box's knuckle. It is a dorsal tear in the capsule of the metacarpophalangeal joint, and one more thing is sesamoid fracture. Indications are non-operative. If there are radial collateral ligament injuries also, if there is a volar or dorsal subluxation. Okay. operative stenosed lesion, unreduced dislocation, failed conservative treatment, complete ligament mid-substance tear, complete tear with bony avulsion, we need to operate. What we do is, if it's a partial tear, we give a thumb spica cast in slight flexion of metacarpophalangeal joint for 3 weeks, and then after 3 to 4 weeks we need to discontinue the thumb spica cast and we go for active range of motion, and after 2 weeks passive range of motion. Surgical treatment for collateral ligament injuries, first is mid-substance tear and tear at the distal end. So if it's a mid-ligament tear associated with bony fragments, if the fragment is too small, we need to reconstruct the ligament. If it's a large fragment, we go with fixation of the fragment with K-wire. Ligament tear with osteochondral fragment. Osteochondral fragment is a very small bone fragment. So if the fragment is very small, we again need to reconstruct the ligament. If the fragment is large, we go with K-wire fixation and thumb spica cast. If the fixation is not possible in the fragment, we go for ligament reconstruction. How do we go for ligament reconstruction? We go with split. We split the flexor carpi radialis tendon and we drill holes in the proximal base of the proximal phalanx and the metacarpal head, and we go with fixation of the tendon graft. So post-op treatment is removable thumb spica brace for 3 to 4 weeks, followed by range of motion exercises. Remove the pull-out stress sutures and K-wire by 4 to 6 weeks. Repairing of the old ulnar collateral ligament injuries using EPB, extensor pollicis brevis, adductor pollicis, palmaris longus. So avulsion fractures to be treated if there is more than 25% of the articular surfaces involved. If there is more than 25% of the articular surfaces involved, we go with fixation of the avulsed bone fragments by means of K-wire. So you can see here that this is the bone fragment which is avulsed here from here. This is the bone fragment avulsed from here. We go with K-wire fixation or screw. Okay. You can see that this fragment here is fixed to this fragment and K-wires are applied. So K-wires are applied. Thank you. So with this class probably we have covered all the topics in upper limb. So next time we will go ahead with fractures of the lower limb. Okay, thank you.